when you talk about COVID-19, when you talk about Ebola, the collaboration, the effort put in by everybody, right from the political level up to the local level.
Every refugee child has a story to tell, and we need to really leverage every bit of this story.
Welcome back to the WSPID podcast series brought to you by the World Society for Pediatric Infectious Diseases. I'm Alicia Chang, a pediatric infectious diseases specialist working in Guatemala City.
And I'm Dr. Jonathan Nkalubo, a local medical officer in the Ebola outbreak response at UNICEF Uganda. I'm delighted to join Dr. Chang in hosting this episode.
So today we are highlighting the major health and infectious diseases threats faced by refugee children, the key barriers to vaccine access and immunization delivery in humanitarian contexts. And we hope to identify solutions both on the program level and individual pediatric infectious diseases professional level. Before we introduce our guest, we'd like to remind you to check out the Global e-learning portal on the WSPID website for access to resources on the topic.
To explore this important topic, we are privileged to be joined by Professor Edison Mworozi. Professor Edison Mworozi is a senior consultant pediatrician at Mulago National Referral Hospital in Uganda. He's an honorary lecturer at the College of Health Sciences, Makerere University, and Uganda Matters University, Nkozi. Professor Mworozi is a member of the Uganda Medical Board, National Expert Committee on Child Health in Uganda, and East African Rotavirus Advisory Board. Professor Mworozi has been involved in Uganda national immunization programs for many years and is a founding member of the think tank Vaccine Safety Initiative since 2008. Welcome to the podcast, Professor Edison Mworozi.
Thank you, Jonathan, for the kind introduction to me, and Professor Chang for joining, for inviting me and hosting me. What Jonathan says is true, but of recent I also chair the Uganda National Measles Eradication Vaccination Validation Committee. This is the committee responsible for seeing our progress towards measles elimination. I also happen to be a member of the National Polio Eradication Committee. And then currently also Professor of Pediatrics at King Caesar University and Head of Department. Thank you very much. I'm excited to join the team.
Thank you, Professor Mworozi. We're really delighted to having you with us in this program today. So we're going to start discussing first understanding the landscape of the issue. So what are some of the most critical health challenges you think we are facing in terms of refugee and displaced children in the setting you've worked in?
I think the most pressing challenges for refugee children, one are outbreaks of infectious diseases, and then of course malnutrition. Those are the key ones. Outbreaks of infectious diseases and malnutrition. So we are talking about infectious diseases, the getting measles, outbreaks of measles, outbreaks of diarrheal diseases, outbreaks of respiratory infections, and then of course we talked of malnutrition. Because there are other things of that, but the key ones are infectious diseases, malnutrition, in addition to those other things.
And Professor Morosi, from your perspective, how do these crises, like displacement, conflict, and these natural disasters, contribute to outbreaks and vaccine preventable diseases?
That's interesting. Yeah, one actually the natural disasters are there, but I think, as Jonathan will know, the biggest in affecting especially Africa are the man-made disasters, the wars and conflict. But for of course the other the natural ones like let's say famine, like drought or flooding and the rest, which are especially got worse with climate change, they are there, but I think the biggest one are the main man-made to do with wars conflicts at home, the displacement from country to country, even within country, are the most critical using, which are associated, of course, with also lack or inadequate supplies of vaccine stockouts. And then the numbers are so much that sometimes when they get these refugees children, the numbers are so high that they cannot be quickly vaccinated. Ideally, of course, they are supposed to be vaccinated at the reception center, but sometimes the numbers are so overwhelming and they come in a big number that they are not able to vaccinate all of them. Either the vaccines are not adequate or they get exhausted before they could get more supplies. Then, of course, there are other things that was being displaced people, that sometimes there are other challenges apart from the vaccine supply. Also, when the number of the health workers is not adequate enough to address them. Because you have the background of also having, of course, not any shelter. You also have no shelter. So, because of having no shelter, then you are also prone to getting these diseases like respiratory infections. Of course, as we said, the lack of course adequate and clean water, safe and clean water, then they get the diarrheal diseases and others. And of course, if they are in the cold, then they are prone to getting also other diseases. So it's a big circle. But of course, when you come to the natural ones, they also suffer the same, but they are easier to handle than the man-made ones to do with conflicts and war and displacement. Where you find also even the refugees themselves have got even the conflict between themselves. Sometimes when they are different from different countries, they are displaced with their own internal conflicts. So sometimes they are difficult to handle. And there's mistrust between themselves and also mistrust with the host countries, that they are not sure what they are doing is intended for their good or not.
Thank you for your answer, Dr. Morosi. Is there a particular infectious disease that you are concerned about in the regions you're working at right now?
Yes, the main ones, of course, uh, malaria, measles number one, then of course malaria, then the respiratory infections, and of course we are getting outbreaks of disease like cholera in there, because of the poor just inadequate water supply, also but inadequate also not clean or safe, so they get those diarrheal diseases. And but measles is among the biggest killer has been measles outbreaks, and of course malaria, and then we talked about the diarrheal diseases and respiratory infections that they heal. And then of course in the background there's also mild and undernutrition as well as malnutrition.
Of course.
Because they also get being the case also, because most of them are not immunized. TB also is common among these. Tuberculosis is common among the infectious diseases, which were preventable infectious diseases. Measles, TB, malaria. Now, of course, now recently we got a malaria vaccine, but previously there was none. And then the diarrheal diseases. And of course, the other respiratory disease, of course, pneumonia, respiratory.
Yes, in my side of the world, we've seen a surge in TB and, of course, measles. It's a big, big issue. So back to you, Jonathan.
Okay, thank you, Professor Mworozi, for laying a background for our podcast. I think also just to add on, being the fact that we're in the same setting, these displacements and conflicts cause overcrowding, and overcrowding tend to see unhygienic practices in the refugee settlements. We have community defecation, and this has contributed greatly
Yes.
to diarrheal diseases. Outbreaks and natural disasters also tend to interrupt the vaccination schedule. Imagine a war breaking out and the child it causes them to miss their vaccines. Okay, let me not dive so much into that. We proceed to barriers to immunization. From your experience, Professor, working with displaced populations through UNICEF or similar organizations, what are the most persistent barriers to delivering immunizations in these settings?
Thank you very much for this question, and that's a very, very, very important question to say that. So, as I said earlier, the biggest barrier is that usually the vaccines are not adequate. They are either not adequate at the beginning or they stock out, because the numbers are so big that they come so suddenly, big numbers that the initial, of course, the countries where they go, where they are displaced, they are using their stocks which they have. So by the time they get extra stocks, these outbreaks have started. So that is the biggest number one. Number two, as you said, of course, also the inadequate health workers to carry out the vaccination and also preventive programs. Then the other thing, of course, which is also one of the barriers, is the refugees. Usually they are suspicious of any activity that is being done for them. They are not sure whether they are safe to have them. For example, the vaccine, they are not sure whether they are being given an effective vaccine or whether they are safe to them. So the issue of vaccine hesitancy by the community with make sure that they be given the right vaccines. Because sometimes the refugees, they are also skeptical about where they are being hosted. And then, of course, as the Jonathan has said, the numbers are so big, they are crowding, and then you find isolation is not easy. So in addition to that, so we said number one, of course, was the stock out. Then there was of course, transportation of the vaccines and even health workers, so the space areas where they are, and is also another challenge. And then, of course, we talked about vaccine hesitancy, and then, of course, shortage of health workers. And then the other thing, which also is another big challenge, some countries which are neighboring countries, you find the refugees cannot be confined in one place. Because ideally, there should be, when they come in, they're supposed to be at reception centers to be vaccinated as soon as possible. I have had a chance to visit some of the areas where the refugees has flocked into the country. Part of my work, as we try to see whether our efforts towards measles eradication, you find that they are health workers, a health unit which is supposed to be receiving them for vaccination has got about 2 staff, and then you have got about 1,000 people coming in at once. So you can imagine how would you, first of all, the staff are not adequate and the vaccines are not adequate. Then the other thing, of course, some of them, you find that the refugees are not sure about, they are hesitant to receive any vaccines from the host country because they are not sure whether they are safe for them. Then, of course, sometimes, but not a big one, where there is sometimes conflict between the refugee communities and the host communities. Sometimes the host communities have got a negative attitude towards them, that sometimes they are cared for more than the host communities. But in some countries, you find the refugees, they are coming in and out. They come in at night, then they go back and come. So sometimes that also encourages spreading of infectious diseases and the rest. And of course, as he said, this unsafe, usually when there are very many overcrowding, because they don't have adequate facilities for washing, bathing, and water to save soul. And of course, we talked about malnutrition. For some, they are not getting adequate feeding, and also, because not only adequate, but also the quality feeding. So you have those health systems factors, but you also have got others, the beliefs. Still, some the people still have negative beliefs about vaccines, and especially with the refugees when they come, they have their own beliefs. The first of all, they come with their cultural beliefs, and when they come, then they are not sure whether your culture meets with their culture. So handling them, and the idea is they would have preferred to be taken care of by their own people, which is usually not possible. Yes.
Okay, thank you very much, Professor Edison, for that. Just to add one, most of the vaccine transportation rely on cold chain. We have very many challenges with the cold chain system of transporting vaccines and also keeping them. And then the prevailing wars in these areas also interrupt transportation. There are ambushes on vehicles that are carrying vaccines and also on health workers who are going to give these vaccines. Our next question is, how do disrupted health systems, security challenges, or lack of infrastructure impact immunization programs?
Oh, that's the key. That's key as far as going. Thank you for that question, because for you to be able to carry out any health intervention, any health program, you need a functional health system. And more importantly, with the vaccines, as you talked about the cold chain. If you want to have a cold chain, it means the health system should be working very well. So that if you get vaccines from the main vaccine store to where they are going, they should be maintaining the cold chain. But sometimes if the health system is not working very well, then, well, one, you may find that the transportation system is safe. You don't have enough refrigerated vehicles which can take vaccine from one district to another, or from the center to the district to the reception centers for the camps. And then the reception center from the district to where the refugees are, you also need to have vehicles which are sometimes in short supply. You also, again, you still need the quantity to make sure that these vaccines, you have the cold chain, those the cold boxes, vaccine carrier, as well as the big cold boxes. And when they get to the refugee camps, ideally they should be having those cold boxes where they may be able to keep the temperatures and keep the fringes and the temperature on time. And some of these places can be so hot that they are not able to maintain the cold chain. Then, of course, we also talked about the health workers. You don't have enough health workers. It's not easy to carry out vaccination programs. And then, of course, also so you'll find the health workers who are few already overburdened, that when you add on this activity, especially when you have big numbers coming in, can be a big challenge, vaccination. I went to one of the center where I found about 500 children who are just coming, the procedure coming, and there was only one health worker, two health workers at the health facility, which was a health center too, which is a small center. And yet the idea that they should be vaccinated as soon as they come in. So the health system really is so key, and sometimes the numbers such that they overwhelm the capacity of the host health system to manage to be able to vaccination. Because UNHCR and the UNICEF, WHO, UNHCR, they come in, but still with much as they come in, the problem is much bigger than can be done, because these people come in a big number at the same time. And then, of course, you also, in addition to that, you have got that the refugees themselves, any intervention, they are not sure whether it is safe for them, or it is good for them or not.
Okay, thank you very much, Professor. I think also it is very hard to track the vaccination schedule in a refugee settlement because most people keep moving in and out depending on the prevailing war. So I think record keeping is very hard, and without data, you cannot be able to advocate for more vaccines. You cannot be able to measure outcome vaccination programs as well.
Yes, I did mention that actually some of getting the actual numbers, because some of them, like when they are neighboring countries, they come in and out. At the end of the day they are there, at night they go back to the home, they come back, so the numbers keep changing, changing. But if you have got adequate vaccines, you can be able to do that. Yes, it's a big challenge. And then, of course, sometimes there is double recording, as we talked about statistics, double recording. The same person will go here, and they keep the numbers keep changing.
Okay, thank you very much, Professor. Our next question will be, what role do misinformation, vaccine hesitancy, or political instability play in these barriers that we've just talked about?
Thank you very much for that question. Of course, the vaccine hesitancy, there are so many reasons why people they have the vaccine. What's all we said? One thing is that their knowledge, they lack knowledge. And what we have said, knowledge about vaccines, whether about their effectiveness and the safety. So because of that, they are very reluctant to have their children vaccinated, or themselves even vaccinated. And if that's the case, then of course even sometimes their own leaders also don't believe in them. So if that's the case, you have got few people not getting vaccinated, because one thing uh, you cannot force them to be vaccinated. Although some countries have got rules that once they come, they must be vaccinated. But that also they take it as if it is coercion. So vaccine also is so big. Well, one thing why the main reason, of course, the one is the lack of knowledge. Second, then think about they think the adverse events, or other side effects of vaccines, and then they also don't know whether these programs are intended for them alone, or they also being matches, because they are giving the same vaccine that they are giving the community, the host communities, but they are not sure whether what you are giving them the same, and what your intention is. Because something that maybe we are doing to reduce them, we are doing it to reduce them, maybe they don't produce and all. So there is also the negative attitudes. And then, of course, there are some cultures who don't believe in vaccinations. So when they come to the host countries, they would expect them that they should not be vaccinated. So, and of course, if you talk about it, countries which are unstable, of course, if the country is unstable, even the host country itself is unstable, then of course, all health interventions are affected. Even your own health workers are not stable; they are moving here and there, and then so it affects the um, health interventions, especially the Nigerian programs. So you need a lot of political support, national support, and administrative support as well as health system support. But once there is instability, political stability, then that is gone. No wonder most of the vaccine preventable diseases are still more common in the countries which are at war. If you take case of measles or rather of polio, it's only two countries which are still having wide polio vaccine, wide polio. That is the country which are Pakistan and Afghanistan, neighbors, just because of wars. So wars are a big, and we know once there is war, almost everything stops. And if you have got something like vaccination, which needs seems to be uh, all right all the time, then it is adversely affected. And of course, also funding, of course. We should not talk about, by the way, we forgot about one of the challenges of vaccination is funding. If you don't have enough funds to provide not only the vaccine, but also logistics, it is difficult for you to. And that's what happened as far as the refugees are concerned. Then there are many. Then you need a lot of logistics, which need the quick money as soon as possible, and they can be a challenge.
Okay, thank you very much, Professor Mworozi, for that. Over to you, Alicia.
Thank you, Jonathan. So we're going to go to our next section, and this section is about strategies that work, and we have called this solutions from the field. The first question, Professor, is can you share a specific program or campaign, perhaps one led by UNICEF or a partner organization, that successfully improved vaccination coverage in a refugee or crisis setting? And if you could at the same time tell us what do you think that was the factor that made that campaign actually successful?
Mm. I think what made the campaign successful was the collaboration between different doctors. You are talking the Ministry of Health of the countries, host countries, right from the top, support from the top of the Ministry of Health down to the districts and even to the health facilities. Planning, then of course you have got the support and the uh, involvement of big partners, the key partners, UNICEF, WHO. You have got other things like the Clinton Foundation, Rotary International, and many other NGOs of us who have been involved in this. So usually the success has been that they plan together. They do all the planning together, the budgeting and the rest, and then of course the training. They organize the training and what training goes the hands with the teams who are going to carry out the vaccination. And then of course they do what they call the micro planning. They are from the top of the building to involve them. And then when it becomes the district level, then of course they are also involved. The key stakeholders, also stakeholders. Some of these of course stakeholders have also got branches or their offices in the district from area. So the key also has been intersector collaboration with the government and the key implementing partner. Of course, usually led by UNICEF and WHO. And then, of course, you have got the Rotary International is there, and local organizations like the Red Cross and others helping in. So the good thing that with immunization, these people have been collaborated so much. They are both in terms of putting in technical know-how as well as funding and mobilizing funding, and of course, in carrying out the mass vaccination. And of course, when you talk about social mobilization, also using the same platform to mobilize people. And of course, recently, success has also been because the media has been very active in that. And I think the social media has played a big role that it can quickly communicate your message to everybody. It has been very successful. Both also even trying to also address the issue of vaccine hesitancy. And this has worked for programs like measles. There's an outbreak of measles, addressing them at national level, or polio and others. And of course, if you go to when it comes to things that are not only measles eradication and others, when you talk about COVID-19, when you talk about Ebola, the collaboration, the effort put in by everybody, right from the political level up to the local level, the involvement is so much more. And in fact, the experience of those, the virus, what we call the viral heart fevers, has actually strengthened our ability to also address other issues. And I think you can see the COVID-19. For example, COVID-19, what some things they do. Some we are talking about personal hygiene and risk of preventing disease. I think it has had an impact. Many people know that hand washing, masking, social distancing can also, in addition to these, can also affect some other diseases also can be affected. But the other thing that intersector collaboration, having all the partners on one side and working together, by the way, working together. But of course, more importantly, is the national leadership that they are really leading the way, especially with measles campaign, polio campaign, and of course we know that in Uganda these outbreaks, the Ebola, the Marburg, Rift Valley, when they come, they quickly handled and they have got what, and they have got course now with the emergency response teams throughout the districts, at national level as well as the district level, they have got emergency response teams.
Okay, we are going to now talk about the role of pediatric infectious disease specialists. And our first question is going to be, what is the role of pediatric infectious disease specialists in responding to or supporting health programs in humanitarian settings?
Of course, the role of the pediatric infectious disease in this kind of resetting is mainly to be a leader of the team and provide technical advice. First of all, talk about the risk of infectious diseases. I mean, people in refugees, as you said, are crowding. That they are at high risk of acquiring and also transmitting infectious disease between the high risk groups because of closeness and overcrowding. And also to we are talking about the lack of knowledge, to give the actual knowledge about infectious disease and which of those infectious diseases are more likely to be affected refugees, children, and how they are transmitted and how they can be prevented. And of course, also in addition, of course, when they get the disease, how they can be managed and how they can be managed. And then, of course, still we also inform the people what is available for them to be able to, first of all, how can they prevent this? And if they do, how should they handle in terms of isolation and management? And of course, most important, the basic preventive measures which we can use, starting from the personal hygiene to group hygiene, and then of course the other intervention, and then of course finally, of course, what do we have in terms of preventing them using vaccines, and also of course they should also be able to train. If there's training the people who are involved in the carrying out the vaccination, both vaccination prevention as well as even the care, because also when you care for those who have been infected, then you give the confidence to the program. Somebody is very sick and you cannot care for them, then they will not even listen to you talking about prevention. And Jonathan knows very well that if somebody wants to use facility and the child is very sick, you start still talking about that you didn't immunize the child. I think the mother will not listen to you. You first manage the child, then you can say, if I've done this not happened. So the PF can play that role. And of course, they give the confidence to the program, by the way. I've been involved in this once when the PF are there. People have the confidence, yes, so both expertise, and you find they really come. And these things that, for example, you're talking about vaccine efficacy, they are good people, who can really array their peers and give them the accurate information, and the people will believe. So it gives the program the confidence and all those. Yeah.
Okay, thank you very much, Professor. Another very key role that the PID specialists do is really advocacy. Go on television, radio, and try to break the myth and also address different issues that people may have.
Thank you very much for that, Jonathan. In fact, it is true that these programs, usually the pediatricians take the role in terms of advocacy, and in terms of even having talk shows, they make sure that the pediatrician, when they are, let's say, on TV or radio, the pediatrician, sometimes they quote them, they give the talk show and even some message which was there. Very, very important. In any case, of course, pediatrician, one of their roles is advocacy for children in general.
Okay, our next question is, how can clinicians who may not be working directly in the field advocate for or contribute to improved outcomes for refugee children?
Thank you very much. As you said, of course, the refugee children, there are some refugee camps which have been there for years and established a good health system, and they have good health centers there, which are also part of some part of government health centers within the refugee camp. But of course, those are not been enough. Even the neighboring health workers, health facilities, they also play a role. Of course, for example, when they need admission, they are admitted in those health centers. So they also need to know about all this, what we are talking about that refugees are more vulnerable than ordinary people. That the refugees are more likely to get these infectious disease outbreaks. They are more likely because of the condition they live in. They are more likely to have this disease. This is which are good and they cause high morbidity and mortality among them. So they should know that have that information. And of course, they should be able also to even educate the communities around the refugee camp. Because the refugees, they are not stable. They go to communities, other communities, interact with communities. They should also be able to tell the community, about the refugees around, they are good places, so be careful to how control measures and preventive measures. And of course, in case they are admitted, they come for the treatment, and then they should be able to treat them, knowing that they are both special uh, special conditions which they get suffer from. They should be able to manage them, and of course also should have key skills of handling people out through such a crisis. So it is important that our health workers they are aware about what these diseases are, how they can be managed, and how they can be prevented.
Okay, thank you very much, Professor, for those insights. And our last question is, what would you say to early clinicians or researchers like myself interested in getting involved in this kind of work?
Yeah, it is important they get involved in this kind of work because we say there is another saying that prevention is better than cure.
Okay, thank you very much, Professor. One of my roles in some of the work I've been doing is basically advocacy. I did a lot of advocacy for COVID-19 vaccine hesitancy using social media, uh, and basically coordinating with medical students all over the country and the continent to demystify different myths that people had about the COVID vaccine. And then I played a very big role in vaccine inequity. Remember, many African countries had not yet gotten the COVID-19 vaccine. So we did a lot of online
Yes.
advocacy, and we saw very many other countries donating vaccines. So I think early career researchers like me can do a lot of social media advocacy, can do now with professionals or paid specialists on research projects, and also
Yes.
contribute to many other projects within the refugee settlements. You can volunteer time to take part in a vaccination campaign or health education talks to the volunteers and maybe children in schools.
And I know you are good doing a great job. Yes, doing a good. That advocacy, yes, very, very important. Very, very important.
So, unfortunately, we have run out of time. But I want to thank you, both of you, for participating in our podcast. And I want to ask if there are any final thoughts or final message that the two of you want to send to all of our global pediatrician and pediatric infectious disease audience.
Yeah, yeah. Personally, thank you very much for this feedback. Such thing about this kind of I think it's also part of the advocacy work. That you can have such these podcasts which can go all over the world and saturate as much as possible. And when you talk about immunization, that has been my lifelong activity. At one time, by the way, I was the only politician in these campaigns and things, with vaccination. But with time, we have convinced so many that we have even set up. Right now, we have put a training center. You have heard of Eastern Central African Vaccine Initiative, where now we are training on a yearly basis people on immunization. And a yearly, this month we're actually doing the 11th, and these are people from all over the country. So I'm getting very many people getting involved in immunization so much, and it's so competitive. People are now realizing the importance of vaccination, and I think, what you're talking about, advocacy, is very important. So thank you very much for giving me this opportunity to share my little experience and knowledge with the wider community.
Thank you.
Okay, thank you, Alicia, and thank you, Professor Edison. My parting thoughts on this, I would like first of all to thank pediatricians and infectious disease clinicians who are working in humanitarian settings. I've been really of late thinking about Gaza, thinking about Democratic Republic of Congo, thinking of Sudan, and many other countries that are currently at war. The most culprits are the children. Many have lost their lives.
Yes.
And we've seen health workers in those communities not leaving their work and running away. They continue to work in these very hard settings. I really commend each and everyone in those settings and encourage you that you're not alone. We are behind you. And our special message to all those who love pediatric infectious disease work. Every refugee child has a story to tell, and we need to really leverage every bit of this story. Besides the vaccines come with side effects, the pain, the painful shots, the infections at sites of injection. We need to really walk the path with them and educate them, because vaccinating them may add a toll to what they're already going through. So looking at them not as candidates of vaccines, but as children who need to be loved and cared for, I think bringing vaccines to these children can help prolong their lives and prevent them from dying from preventable illnesses, especially in these times when curative services are out of reach. So thank you very much, WSPID, for bringing this important topic, and Professor Edison, an expert in this area, for joining us today. Thank you very much.
Thank you. It's a pleasure.
And that's the end of today's episode. Thank you to our esteemed guest, Professor Edison Mworozi. To find further resources and educational content, you can visit the Global e-learning portal on the WSPID website, your hub for pediatric infectious diseases insight.
Thank you for listening to the WSPID podcast. Make sure you're subscribed on your favorite podcast platform so you don't miss an episode. Please share the podcast with your colleagues, leave us a review, and be sure to tune in next time.